We did a study that was reported out last year in Lancet GI Hepatology that was looking at neoadjuvant Cemiplimab, which is the PD-1 antibody for HCC. And I think the liver cancer space is particularly intriguing for perioperative therapy because so many of the patients actually recur. And here at AACR, there actually is some adjuvant data looking at Atezolizumab and Bevacizumab that shows a recurrence-free survival benefit. But we've been looking at the neoadjuvant setting because we have lots of data preclinical and clinical to suggest that neoadjuvant immune therapy or perioperative immune therapy is better than just adjuvant immune therapy. So we did a trial where we treated patients initially just with 2 cycles of Cemiplimab. They then went to the operating room, and most of the patients then got 8 cycles of adjuvant Cemiplimab. And while we were doing that, about 1/3 of patients ended up having a significant amount of necrosis, and 2/3 of them we didn't see a significant amount of necrosis. But we also collected blood at multiple time points, including with cycle 1 and cycle 2 that was given right before surgery. And we noted that all of the patients who had a significant pathologic response had a significant decrease in their ctDNA. But intriguingly, about a half of the patients that did not have significant tumor necrosis when we resected their tumor also had a drop in their ctDNA. And it does seem like this drop in ctDNA, this early drop that we're seeing between cycle 1 and cycle 2, correlates nicely with long-term remission. In the subset of more than half the patients are still in remission, which is much better than we would have expected with these patients who had pretty advanced disease. So this is definitely an early stage finding. Obviously, it's not ready for prime time, and it needs to be validated in larger neoadjuvant or perioperative studies. But I think it re-emphasizes what we've seen in other tumor types where we can use ctDNA dynamic changes and predict outcomes using that data. Also, one finding that we had was that in patients who had detectable ctDNA after surgery, they had a very high risk of recurrence, as you would expect. All of them ended up recurring. And that first time point after surgery is a very good marker, sort of a bellwether of how patients are going to do. So I think the data that was presented here, the EMBRAVE data, really does confirm that we should be giving an adjuvant Atezolizumab and Bevacizumab. And I definitely wouldn't advocate depriving patients of that, but I think that there is significant benefit to giving some priming immune therapy before surgery as well. And we really have to explore how to do that and what agents make sense to give preoperatively versus postoperatively. I think I'd be a little bit worried about giving Bevacizumab before surgery, and typically we have to wait for at least 6 weeks after the most recent dose of Bevacizumab before we would take patients to the operating room. So there's much more of a delay of surgery if you use that in the preoperative setting. But I do think that it makes sense to give some priming immune therapy beforehand. That really enables your immune system to prime de novo T cell responses, and also helps the pre-existing exhausted T cell responses in patients with a large tumor antigen burden. And then in the postoperative setting, giving additional immune therapy when there's only hopefully micrometastatic disease remaining. I think that we're really going to see this significantly decrease the likelihood of recurrence after surgery or any curative intent therapy in the HCC setting.